Everyone. Welcome to the Happy Flosser podcast. My name is Billy Luntz. I am your host, and I'm here to talk to you about all things dental hygiene to support you on your journey through the dental hygiene program. It is really great to be with you today. Today's topic is about non-surgical periodontal therapy. What's interesting about talking about this subject. This is kind of the heart and soul of the field of dental hygiene. And what I find so interesting, and I experienced this myself as a student, when I graduated, I had a clear understanding of when a patient needed non-surgical periodontal therapy. I didn't necessarily know kind of all of the steps involved because I saw patients and maybe I only was able to somebody who needed non-surgical periodontal therapy. Maybe I scaled one or two teeth in clinic that day. I wasn't doing quadrant scaling or anything close to that when I was in school. And what that did was that left me a little bit confused when I got out into the field as to, okay, what does it look like when my patient has periodontal disease and what are we doing? What I don't really understand all of the parts and pieces. And I got to tell you, so students get out into the field and they understand staging and grading because they are taught staging and grading, right? The new AAP classification system. And then they get out there, and maybe the other hygienist that they're working with learned the other, previous to 2017 paradigm or theories associated with non-surgical periodontal therapy. Or maybe they still call it scaling and root planing. And so there's this really interesting shift that happens when you get out into the field because you were not afforded the opportunity in school to actually do quadrant scaling, as they call it, or non-surgical periodontal therapy as it would be done out in private practice or public health, but you have all of the parts. It's just putting them all together. And what happens when you get out there, if you are working with other members of a team that have a different philosophy or a different approach, sometimes things get a little muddy. So my whole hope of this podcast episode is to kind of talk about the old paradigm, the new paradigm, and what different types of debridement there are, so that can help you as a student or an early clinician navigate the challenges that you face when you get out there putting all the parts together. So, and this happened when I graduated from school. So the old paradigm was that you did scaling and root planing. So scaling was instrumentation of the crown and the root surface, essentially to remove the plaque and calculus that existed on the tooth. And then root planing was the theory was that you removed the altered cementum on the surface that was rough or impregnated with calculus. So if there were rough areas on the root surface, they wouldn't technically heal unless you did root planing and made them as smooth as glass. I can still remember my faculty saying smooth as glass. And what ended up happening was we ended up with thin and fragile roots. We could actually see over time that we were causing damage to that cementum in our patients and maybe not getting the results we were looking for with healing anyway, even if there was smooth as glass root surfaces for our patients. So the new paradigm was we talked about the introduction of ultrasonics. You think about how all of the progression was happening at the same time. So we were developing a really thorough understanding of dental biofilm and the biofilm byproducts, and that sometimes removing the calculus didn't necessarily promote the healing. But if you disrupted the surface irritants, like the dental biofilm, and you were able to control the biofilm and their byproducts, along with the calculus removal from the crown and the roots, and then also thought about the lining mucosal that was in the gingival sulcus and used manual or power-driven methods, thinking about an all-encompassing way to treat our patients that presented with periodontal disease would promote healing. And it was not necessarily on the radar when the old paradigm was in place. So I would have a patient with absolutely no calculus on a tooth and still have irritated tissue or deeper pockets or a long junctional epithelium. So, this transition of really developing a thorough understanding of biofilm and its impact on the tissue and the progression of disease, and then biofilm management, has really made a lot of sense for the experienced clinician who dealt with patients who had periodontal disease with non-successful achievement of stability and health. So when we talk about different types of debridement, you have supra and subgingival debridement, right? The calculus that's above the gum line, the calculus that's below the gum line, but also the dental biofilm, right? That's above the gum line and below the gum line, along with stain removal. And part of our job in doing debridement is to remove any burnished calculus from prior treatments. So, endotoxins are also a consideration that we have to think about when we are doing non-surgical periodontal therapy. So, when we are doing a debridement, endotoxins are waste products from the bacteria, typically gram negative. So, it's not just about removing the calculus. So, when we are disrupting the substances found within the epithelial tissue and the pocket. So maybe we're using a laser to detoxify the lining mucosal tissue, and we're using our ultrasonics and airflow to remove the endotoxins from the root surface. These are all parts of the debridement process. It's not just about the instrumentation. I want you to think about the root surface, the crown surface, but also the lining, the gingival sulcus, the lining, because we know that the byproducts and the biofilm, all the little bugs that you learned about in microbiology, they get into that tissue and they cause destruction. So if we can treat the entire area, detoxify the entire area to remove the load, we can really improve the opportunity for healing. So let's talk about the steps in non-surgical periodontal therapy, because a patient will ask you, what are you doing that's different than just a cleaning, right? That's the infamous word. I'm not opposed to saying the word cleaning to a patient because it bridges the gap of understanding, but I'm certainly open to following up the word cleaning with what we're really doing. And I think we can really be intentional about educating our patients as far as cleaning. I mean, cleaning is what they do at home. That is not what we do. So let's talk about the steps involved in what we actually do to really promote an understanding of more than just a cleaning. Um, our patients, if they can understand what we're doing and what the steps are involved, and just by sharing that, they will develop their own understanding that what we're providing for them is more than just a cleaning. So I always like to start with the ultrasonic explanation. Using my ultrasonic scalers provides fluid lavage. It's a mechanical disruption of the free-floating, unattached subgingival biofilm from the sulcus and the pocket space. It's like an oral irrigation. I tell patients sometimes, depending on their level of understanding of what's going on, it's like having a pressure washer, right? So you're flushing out all the free-floating bacteria, you're reducing the toxins that are in that pocket space so that you can promote healing and support the immune system. And sometimes in non-surgical periodontal therapy, we use antimicrobial agents. These are some of the adjunctive therapies that we use specifically targeted to our specific patient for the control of the pathogens. So if you're doing saliva testing and you know exactly what pathogens that patient has in their mouth and exactly what antimicrobial agents will be effective for that patient, then that's what you're going to use. Um, And then you are doing your own research as a clinician to discover what types of adjunctive therapies would work best for this patient. Do they need a mouth rinse? Do they need a prescription toothpaste? Do they need a povidone iodine? It just depends on what you're seeing, right? So perioprotect trays. What are the things? What are the therapies, the supportive therapies that you are thinking about providing your patient? And as you're doing your treatment planning and implementing your care, these preventive agents and supportive therapy agents are the things that you want to be thinking about. What would work for this particular patient as I'm working through helping them go from a disease state to a stable state? So, the steps in non-surgical periodontal therapy, you are really looking at the biofilm control. Part of that is the educational piece done by the patient. That daily biofilm control by the patient is probably one of the biggest components of treatment and successful maintenance. I tell students all the time, if you only had a certain amount of time to spend with your patient and you had the choice of scaling one more tooth or providing education, which one do you think would be more beneficial to your patient? It's not always about the calculus, because that behavior change that you will see in your patient as a result of educating them, listening to their struggles, listening to their challenges and some of their behaviors, and really walking them through the process of understanding the significance and importance of good biofilm control, that's successful. That's successful maintenance that you're going to see on your patient long term down the road. And it's one of the main steps in non-surgical periodontal therapy, right? You're going to use your ultrasonics, your airflow technology, your instruments. You're going to be really mindful about removing all those irritants, the calculus, the endotoxins that are in the lining mucosa that are against the root surface. But what are you going to do about education and adjunctive therapies? These are the parts that are really significant in a patient who's in a disease state versus somebody who is healthy. So think about that. And what I love about the new disease classification system is the patient's host response factors. Those pieces are evident when you are diagnosing the staging and grading of your patient. So when your patient's periodontal disease progresses based on that host response, it's important for you to make that link, right? Medications, smoking, diabetes, some kind of systemic illness that that patient has, those are all going to play a role in how your patient responds to non-surgical periodontal therapy. And I have to tell you, so I was always amazed as a hygienist that when I did non-surgical periodontal therapy, I could have two patients exactly the same. Maybe they were both stage 2 grade B periodontal disease. You know, they both had stage 2 grade B periodontitis. And one would respond so well to treatment, and the other would have these struggles. So you can't rule out some of those systemic contributing factors, and you really want to dial down, kind of lean into what could be contributing to those disease progression areas, and really seek out the advice and support of the periodontist so that you can really help that patient get their periodontal disease in remission. Right. So we are looking for stopping the progression of disease, eliminating the bacteria, decreasing the infection, and putting periodontal disease into a remission state where there's no longer attachment loss or bone destruction. So these are the things that we're looking for. And these are the outcomes that we want to share with our patients as we're walking through the process with them. One of the best parts about non-surgical periodontal therapy is that you see the patient multiple times to treat them. Right. And that is creating an environment that encourages tissue to heal. It's also building a relationship and supporting the patient. We want to help them convert those pockets to a manageable pocket depth, right? Shrink that enlarged tissue to make it so that the patient can actually maintain that tissue health. And by seeing them in sequential order and getting them through the non-surgical phases of treatment, it provides you the opportunity to do just that. It gives you that time to educate the patient in little tiny incremental steps. But the other piece that's really cool is that when they start to see outcomes, they start to see positive outcomes. Maybe you have done non-surgical periodontal therapy on the right side, and now you're going to see the patient and you're going to do the lower left, and the patient comes in. Oftentimes, you can use that time to show them the difference in the tissue healing. Right. And on a microbial level that before you've treated that area that there's anaerobic gram-negative rods and there's filaments and spirochetes and there's high bacterial pathogen count. And then after you've treated that area, it's more gram-positive, there's a low cocci count, there's non-motile, there are aerobic pathogens. But what the patient sees is that the tissue is healthier. The patient might actually feel the difference in their mouth. They might actually feel that the tissue is shrinking and that it's appearing better. Now, I want you to remember that when you first started learning about the gingival assessment, everything looked pink to you, or everything looked really red. There was no in between. So don't expect that your patient is going to see the marginal redness disappear because you had a hard time learning what that even looked like as a student when you first were learning it. So the big swings is what your patient is going to notice, right? We want to induce positive change. We want to delay that repopulation of those microorganisms in the pockets. We want to reduce the etiologic and predisposing factors like the calculus and the rough surfaces that will actually create biofilm adhesion. And honestly, guys, the most important part, I believe, is the motivation of the patient. They appreciate and value a healthy mouth. In that, appreciating and valuing a healthy mouth is when you help them connect the dots between their systemic wellness. How does taking care of my teeth and gums impact my overall wellness? Because you can have a lot of patients that are focused on health, but not necessarily realize that they have active infection going on inside their mouth. So it's up to you to help your patient make that commitment to oral and overall health and really to commit to performing that biofilm control. And honestly, one of the best things you can do is listen to your patient. Listen to what their challenges are. Try to develop a listening ear instead of filling them full of educational pieces and tons of information. Listen to what their challenges are. Maybe they're really, really busy. Maybe they have too much on their plate. Maybe they have a high stressful job. I want you to consider catering your recommendations to them based on what they tell you are their challenges in their life, their limiting beliefs, the issues that they have that got them to this place that they are right now. And, I can't stress enough that you have to always evaluate the tissue, determine if you're being successful. Involve that patient in that process. Maybe they're still bleeding on probing in this one area and you have a little irritation in the tissue and you're just not happy with how it looks on the radiograph following non-surgical therapy. And you want that patient to go see the periodontist. Have those conversations, show the patient what's involved, show the patient what you're concerned about. You know, those are all the pieces that really involve the patient in the process. Okay, I'm just going to touch on this because this still goes on. Please do not do a gross scale. Do not do a gross scale. I don't even know what a gross scale is. I have to tell you, one time I opened up a note and it said, um, scaling and root planing, gross quadrant scaling. I honestly didn't even know what to think when I read that a hygienist wrote that they did a gross scale in a quadrant. I was like, I don't even know what to do here. So think about this. You, every tooth should be scaled to completion because if you take some of the calculus off in the pocket, the gingiva may heal a little bit, making it really difficult for you to reach the remaining calculus when you do instrumentation. Um, it could form a periodontal or gingival abscess because at the gingival margin, the tissue may heal, but then deep in the pocket, there's not ability for the endotoxins to go anywhere. the rough surface or of calculus that you leave behind when you do a growth scale actually encourages more biofilm retention. So just don't do it. I will say the closest thing that I've seen to a compromise of doing a growth scaling versus just scheduling the patient for non-surgical periodontal therapy is to remove some of the above supragingival calculus. And that I've seen be okay as long as that is the commitment that the hygienist makes to the process. And honestly, most of the time involved in that assessment piece, when you've made the determination that your patient requires non-surgical periodontal therapy, is education. Education. You should spend that time doing education because when you just start doing a growth scale, your patient's even more confused as to what you're actually doing and why they need to come back. Well, didn't you just clean my teeth? They feel better because you just took the calculus off the supragingival areas, and they just have no idea what's lurking beneath the surface. So it's really complicated. It's really, and that's the problem when you get out in the field is that we can all agree that if we take courses together, that we can learn how to stage and grade together. It's the other piece that is complicated. It's the part where, okay, I've staged and graded my patient and we've come up with a diagnosis. Now what's the treatment plan? And I have seen 28 different treatment plans provided to patients that are stage 2 grade B. It's just insane to me that we have different philosophies out there as a basis. I think that's what makes it hard for combining the old paradigm with the new paradigm and putting all of that together into one cohesive, understandable treatment plan for a new graduate. So I feel you guys. I feel you. I see the challenges that are out there. The other piece is the insurance. Some offices do the growth scale first because the insurance will pay for a growth scale. I will tell you that the only time you would ever do a growth scale is if you can't probe the teeth. If you can't actually do an assessment, that is the only time you would treatment plan for a growth scale. And I've been a hygienist a long time. I've never had the need to do that. So why that's still an insurance code, I don't know, because I do think it causes a lot of controversy as far as what we know, what the evidence tells us, what the science-based, evidence-based treatment plan should be, and then what we're really doing. So when our patient presents with active infection, we can take the time in that appointment to provide them with education, understanding what's going on in their mouth. Take the time to show them the radiographs, show them some intraoral photos, give them one piece of information that they can use at home to get them prepared for coming back for their non-surgical treatment. How you manage it is up to you, but that is non-surgical periodontal therapy in a nutshell. Most offices do it by quadrant. I have had some patients with pretty advanced periodontal disease that I did in sextants. We did 6 visits and then sent them to the periodontist following that, but that was a rare case. Oftentimes, I would say most of the time, you will do treatments of quadrant dentistry. And I know that's hard to believe while you are a student learning, but I know that when you get out there, you will develop that understanding. Like I said, the hardest part is not coming up with your stage and grade and diagnosis. It's what happens after the stage and grade and diagnosis that has some students tripped up. So always follow what you've learned, what you know about periodontal disease and successful outcomes associated with periodontal disease. It's half of it is about what the patient develops for understanding, the motivation that comes out of your education, and the treatment that you provide the patient. So it's not just one piece. There are so many parts to it that all come together. And I haven't touched on all the different components because this is just a 20-minute episode, but more to come in the future, guys. Just stick with what you've learned, stick with what you know, and always continue to learn and grow. I will talk to you soon. Have a great week.